The next speaker is Dr. Arthur Kundo, a clinician of 25 years. He's been involved in mental health sector for the last 20 years as well. He's a senior psychiatrist at Indira Hospital and also a university lecturer. Please come and share with us, Dr. Kundo. Please make him feel welcome.
Honorable Vincent Biruta, Rwanda Minister of Foreign Affairs, co-host of this event. Honorable Dr. Abdul Momen, Bangladeshi Minister of Foreign Affairs. Honorable Vincent Biruta, Rwanda Minister of Foreign Affairs. Honorable Patricia Scotland QC, Secretary General of the Commonwealth. Dr. Tedros, Director General of the WHO. Honorable dignitaries, esteemed advocates, distinguished guests, good evening. Thank you all for joining us for this crucial event. The timing couldn't be more appropriate. We are gathered under the reality that as we speak, according to the WHO, 1/8 of the people we know, 1/8 of the people that we love is affected by mental health problems. If you would allow me, esteemed guests, I would like to address the elephant in the room. As none of us is strange to the health crisis that the world is currently straining to overcome. There are events that take a toll on the mental well-being of entire populations. And unfortunately, Rwandans are all too well placed to know this. Our history is not only marred by the trauma of loss and undeniably of dehumanization, our history is also defined by the monumental effort of overcoming, following unimaginable collective psychological, physical, and emotional suffering. Dear guests, the world has lost 6 million people to COVID-19. Millions of families have been ravaged by premature death, and billions of people have suffered the COVID-19's financial and social strains. And the bitterness of the COVID-19 wake-up call may long remain, ladies and gentlemen. But the prevalence and rapid increase of poor mental health among our children, our neighbors, our friends, our fellow Commonwealth citizens must be done with. We must act, and this no later than the day following yesterday. It goes without saying, ladies and gentlemen, that mental health transcends the health domain. Poor mental health breaks down our communities by disrupting the wellness of families, poisoning our socio-economic development. Presently, poor mental health costs the world economy an estimated $2.5 trillion every year. This hemorrhage of resources, this costly human tragedy makes one thing clear. Mental health is the bedrock upon which the welfare of our communities lies. We cannot allow this foundation to crack without us joining forces to solve it. Honorable guests, allow me to make the case for substantial resource attribution to the protection and support of mental health from the lens of a country that has seen firsthand its importance in survival. Over the last decade, Rwanda has tried to implement homegrown solutions by our citizens, for our citizens in mental health and beyond. Over the last Imbuto Foundation, in collaboration with the Rwanda Ministry of Health and strong partners, recently launched the Bahoneza mental health program in Rwanda. Bahoneza attends to the mental health of Rwandans, very firstly on earth, by ensuring the holistic wellness of the mother. Committed to actualizing a brighter future, Bahoneza defends the health of Rwandans throughout the life, and indeed, the birthing life. Ladies and gentlemen, the time is now. We need and must invest more financial resources in mental health research, prevention, skills, training, and treatment. We need and must eradicate mental illness stigma and develop a global culture of tolerance and self-accountability. We need and must deploy effective collaboration between mental health experts from public and private sectors, from state and non-governmental agencies across the Commonwealth to build resilient structures of mental health support. I thank you for being here and to define the way forward and improving mental health in the Commonwealth member states. There is no health without mental health. There is no development without mental health. There is no brightness in our shared future without mental health. And ladies and gentlemen, there is no Commonwealth without common mental health. Thank you. The host of this event.
Good morning. It's a great honor to be with you today, to not only to participate in this great congress, but also to be with you and share with you on this topic of quality of health, quality of life in neurology and psychiatry. I don't know what I can add after this speech. This is the best speech I've ever heard about brain health. Because here we are talking about brain health. We are sharing about brain health. And let me start by that quote that we see that is not well visible. There is no health without mental health. There is no health without brain health. So here, as we see, we are talking about advancing brain health and mental well-being. Our First Lady has mentioned about stigma, and let me tell you that there is stigma. There is stigma about mental health. There is stigma about brain health. So it's good. This is a brain week. But if you see, we have from the first day, it is stroke, it is epilepsy. It is not even all chapters of neurology. Yes, but have you heard about chronic stress, for example? Have you heard about depression? Have you heard about schizophrenia here? So that are very clear. For example, here in Rwanda, 1 person in 5 is affected by a mental health problem, a mental health condition. And who's coming to consult? Very few. So 20% of the population is too much, isn't it? It's too much. The 20%, how many are consulting and how many are treated? Also, it's less than 10%. So you see that we have a great job to do. So before I continue, let me salute all professors who are here. You are in Kigali, you are in Rwanda, please welcome back. May this Congress not be your last time to be in Kigali, Rwanda, to share with you or to meet you. Because when we are with you, we learn a lot. I did my residency in psychiatry in Senegal, in Dakar, and it was a great moment for me. And let me share with you that I refused to do my residency in Rwanda. So you can ask me why. Because when I finished medical school in 2000, I take time to decide about the specialization that I can do. So the question comes and says, if people who have trained you to become a medical doctor, are they the one who will train you to become a specialist? This is not. You understand? That is why I say, okay, let me go abroad to do my specialization. And we still have few professors in Africa. We still have few professors. If I say here how many professors are in this room, you will see there will be 3 or 4. So I'm a senior psychiatrist. I'm a psychiatrist now. In practice since my journey in psychiatry started in 2005. And now it's 20 years. So stigma again is there. You know, when you are a medical doctor and you decide to become a psychiatrist, you know how your colleagues here see you? Say, Doctor, how? You go in psychiatry? You want to become a psychiatrist? Say, you know, it seems like it is the last choice you can do. You know, it seems like it's the last choice. How you become a psychiatrist while you can be a good gynecologist or a good surgeon? I remember I did my thesis of medicine in surgery. I was very good in surgery, but the destiny is the destiny. Your destiny is your destiny. Your choices are your choices. Don't let anyone choose for you. Because if someone else chooses for you, you will become what he wants you to become, not what you want to become. That's a problem. And if you face problem, and if you face challenges, you will, you'll stay down. So, psychiatrists, I think I'm the only psychiatrist in this room. Is there anyone else? A psychiatrist, not resident in psychiatry. A psychiatrist. How many here in this room? Do you see the stigma? Do you see the stigma? This is because psychiatry or brain health is not well explained to young doctors who are finished. It is not well shared. Today, up to date, the training of a young medical doctor who wants to become a doctor, a GP, he comes in their hospital, which is the only hospital we have in Rwanda. The only one. For 2 weeks. So how can you compare? I do my residency for 4 years and my residency for 2 weeks. You see the... Yes. I've been in Senegal. And in Senegal, a young doctor, an undergraduate, he is in the department for 1 month, not 2 weeks. And fortunately there they have professors. I remember even the chief of the unit where I was a professor. But the reality is not the same in other African countries. You know that we have even African countries where they have just one psychiatrist. One. So can we say that there is no health without mental health? Can we say that mental health transcends the health domain? I don't think so. So there is a lot of work to do. As you see me here, I have served for like 25 years. I'm a Rwandan psychiatrist, but for now, I'm an African psychiatrist because I want to expand my expertise in other places where they don't have psychiatrists and encourage young doctors to become psychiatrists. So if you see in Africa, because we are saying about Africa, how many neurologists do we have in Africa? And how many psychiatrists do we have in Africa? This is brain health. So I salute the presence of my colleague for many years here. Let me tell him to go up. I'm talking about Dr. Awasiremo, please. A great doctor who helped children. Why I call for him? Because we have to work together in our practices. You know, we have to communicate it together. We have to share our practice. When you have a limit, call your colleague. Yes. So we have to complete ourselves in our practice. So let me go with the presentation. Improving quality of life. I'm sorry for the mistake there. Quality of life for neurologic patients. Yeah, living with a neurological disorder is, can significantly impact an individual life. Disorders such as Parkinson's disease, epilepsy, Alzheimer's disease, or stroke can alter physical capabilities, disrupt cognitive functioning, and affect emotional well-being. Well-being is there again. Mental well-being. Neurological disorder result from abnormalities in the brain, the spinal cord, or nerves that can cause a wide range of symptoms, including movement problems, pain, confusion, even memory loss. So, apart from the physical discomfort, individuals living with neurological disorder often experience emotional distress, including feelings of frustration, fear, anxiety, and sometimes helplessness. So I have 4 minutes. I will accept for me to be a little bit fast. So, healthy lifestyle. What is a healthy lifestyle? So there is mental well-being. So maintaining a healthy lifestyle forms the bedrock of managing any health condition. Consuming a balanced diet, rich in food. So the diet is back here. How is our diet? You know, because I didn't tell you. I tell you about my experience. But let me tell you that I don't look my age. It's a secret that some people here knows, how old am I. But I don't look my age. Why? Because what I've learned in medicine, I applied in my life. So here we are talking about half of the population, but we have also to think about health or well-being of practitioners in health. You know how many doctors are suffering from diabetes, blood pressure? So allow me to talk about also lifestyle, because lifestyle is very, very important. Okay? So balanced diet, rich in fruit, vegetable, lean proteins, and good brain can help maintain overall health. Regular physical activity. How many here do sport every day? Every day. According to WHO, we must do sport every day. 30 to 45 minutes per day. Nino kora sport hano buri munsi. Who do sport every day 40 minutes per day? Doctors. So I do. Very important. Yes. So if we want to give health, we must be healthy, isn't it? Yeah. Tell also the patient abilities can enhance muscle strength and coordination, improving mobility. Physical exercise also plays a crucial role in boosting mood and combating symptoms of depression, a common occurrence in individuals with a neurological disorder. Following the prescribed treatment plan or taking medication as directed and keeping regular medical checkups can significantly improve the management of neurological disorder. So many patients we follow in our settings, they don't have a good discipline of observing our treatment. That is why many of them they come back in a bad situation. So it's crucial to report any new symptoms or any exacerbation of existing ones to your neurophysician promptly. This open communication allows for timely adjustment to treatment plan and helps prevent complication of disease. So physical therapy and rehabilitation. is very, very important. So physical therapy is a critical component in the treatment plan for many neurological disorders. It helps to improve mobility, strength, and balance. So stress management is very important here. So stress, many people are stressed, you know. Many. And unfortunately, many, they don't know how to manage stress. We all face stress, but the management, how we manage stress is different. That is why people must know how to manage stress. And remember that all chronic conditions, they have behind a chronic stress situation. So very important to talk with your patient and see how to manage, how to tell them how to do a good psychoeducation and tell them how they can manage their stress. So managing stress level is essential in patients living with a neurological disorder. Mindfulness also technique, meditation, and yoga, can help reduce stress and promote relaxation. Hobbies that provide joy and fulfillment. Ask yourself, what is my hobby? Yes, very important. Because when you are in a relaxing moment, you must be in a hobby place, in a place you like. Yeah. So, such as music, or art, or gardening can also serve as effective therapeutic moments. So, thank you very much. I see the time is over. Let me show this. This speech is very important for stress management, for yourself, for ourselves, and for our patient. So as you see there, the doctor must be there. The health practitioner must be there to add his input. Music is very important. I think tomorrow we'll have time for music, all of us. So to go in spa is very good too. Yes. Time management. Time management is very important. I see my friend there. So, and to go in nature also is very important, and to do sport, of course, is very important. Thank you very much for your
Thank you very much.
yes.
One of the things I've learned this morning is that there's a common thread. There's a common thread, and the common thread is that there's a lot of how do we upscale, right? We don't have enough neurologists. We don't have enough psychiatrists. How do we upscale, right? If we're training people for 7-10 years, right? How do people right now get the help that they need, right? So, and the common thread is a challenge. That's right. And the common thread here this morning and yesterday and a few last days we've been here is that we need to work together. We need to share. A lot of sharing, and we can leverage technology, I think, in that way. But before I give the mic to the floor, I would like you to Dr. Rukundo, to just give us a summary or a resume, a summary of what you just said about Yamana, just 2 minutes.
Murakoze cyane. Natangiye nivuga ndi umuganga maze imyaka 25 nkorera mu Rwanda. Muri myaka 25 nkaba narafashije narabaye mu bijyanye n'ubuzima bwo mu mutwe ku myaka 20 mazemo. Murumva aho nkorera mu bitaro bya Ndera, ibitaro bizwi cyane hano mu Rwanda, kuko unarebye ibyo bitaro byonyine dufite mu Rwanda bifasha abantu bafite ibibazo byo mu mutwe. Muri iyo myaka 20 nabonye byinshi. Ni n'ibitaro bifasha abantu bafite ibibazo byo mu mutwe, nabyo twita maladie psychiatrique, ariko bikanafasha n'abantu bafite ibibazo by'imyako cyangwa maladie neurologique. Hano turi kuvuga ku bijyanye n'ubuzima bwo mu bwonko. Abantu benshi bakunze kuvuga ku buzima bwo mu mutwe, ariko hari ubwonko hakaba n'ubuzima bwo mu bwonko. Ubwonko bushobora gukomereka ukagira paralisi, bashobora kugutera ibuye ku mutwe, cyangwa bashobora kukubita icupa ku basore basohoka, bashobora kukubita icupa ku mutwe ukagira ikibazo cy'imyakura. Hari ibibazo byo mu mutwe, sibyo? Ariko hakaba n'ibibazo by'ubwonko. Umuntu wese ujya kwivuriza ku bitaro bya Ndera ntabwo biba bivuze ngo afite ikibazo cyo mu mutwe. mubyumve neza. Hano turi gutanga ikiganiro tuvuga ku kuntu umuntu wagize ikibazo cyo mu mutwe cyangwa cyo mu bwonko agomba gufashwa. Nabivuzeho nta gufata umuntu, murabizi hano twabibonye, umuntu ni mugari, uwo muganga nawe uri mugari. Umuntu naza kukwivurizaho ntukarebe ibimenyetso gusa, reba n'ibindi bibazo ashobora kuba afite, kuko birashoboka. Mwabonye umuntu wigishije hano mbere yanjye yavuze ku bibazo by'ubuzima, kuri trauma umuntu ashobora kugira maze akaza akubwira ngo arwaye umutwe. Utamuvuye, utamenye ko afite ikibazo cy'ubuzima yahuye nacyo, ntabwo wamufasha neza. Uwo atanga ikinini, ariko ikinini ntabwo cyajya kuvura trauma. Mwabonye ikiganiro nyakubahwa First Lady yatanze. Njyewe kiriya kiganiro ndagikunda cyane kuko harimo amasomo. Aratubwira ko iyo nta buzima bwo mu mutwe umuntu afite, nta buzima aba afite. Tuzajya twiyitaho, tuzajya tumenya ukuntu tugomba kwita ku buzima bwacu bwo mu mutwe, tubone umwanya wo kuruhuka, umenye ibyo ukunda, usohokera aho ukunda. Niba uri umuntu ufite urugo, sohokana n'umugabo wawe. Niba uri umuntu uri aho ufite akazi, ntukore kuva kwa mbere kugeza ku cyumweru. Hanze hari abantu bakora kuva ku mbere kugeza ku cyumweru bataruhuka. Reka mbabwire ko bari abantu abakiriya banjye, umuntu wese uzi ko ataruhuka, umunsi umwe aza muri biro yanjye. Ko kutaruhuka, kutaryama, turi mu isi iri kwihuta cyane. Udasinziriye ejo bundi uzaza. Ni byiza kumenya kwiyitaho. N'abarwayi batugana turabigisha. Hari abo dukoresha siporo, hari abo dukoresha physio, hari abo dushyiraho ka music, kuko ushobora kuba uri aho mu gihe turi kukuvura tugashyiraho indirimbo. Mu gihe turi kukuvura, mu gihe bari kugukorera physio bakakubaza ukuntu ubayeho. Kuvura umuntu ni ukumuvura muri rusange. Erega n'Abanyarwanda barabivuze, umuntu ni mugari. Nushaka kumuvura umuntu neza, uzamuvure mu bugari bwe. Murakoze cyane.
Thank you very much for the insightful talk and really the challenge, not only to us as professionals, but to the nations of Africa as a whole, with particular reference to the needs of psychiatry support in Rwanda. And I really hope the government takes heed of this. The unfortunate situation is you cannot be reproduced or recycled within a very short space of time. So to think of getting psychiatrists in Rwanda like another 10 or so, God knows how long that will take. But what can be considered is the possibility of training some of the healthcare workers or community psychiatric nurses who can learn some skills, whether it's in stress management, identifying depressed patients, identifying other aspects of mental health, that they can give some basic advice to these people where they are in their homes, and then escalate those who may require to be escalated because the condition is so bad. That's my first recommendation. My second point is about the issue of the stress management and things like that. I think one aspect with this is the prevention of stress. That also needs to be emphasized, because we as individuals, we have the right to prevent stress to hit us, because we accumulate things, problems one after another coming to hit us. We don't know how to say no to people who demand our time. We always keep giving in until one day we can't do anymore, and we feel the world is on top of us. That is our making. So we need to prevent that from happening, then we are not overwhelmed. Secondly, we need to make sure we pat ourselves on the back to be happy with what we've achieved. There are many people who move the goalpost. The moment you achieve something, then it's not good enough. You have to achieve more. You have to achieve more because you refuse to be happy. Why can't you be happy with what you achieve? So that also makes you become more stressed because you're not actually looking after yourself. So there are many of these things that we can look at. There is a statement that says, you can't control your thinking, but you can control what you dwell in. So let's control what we dwell in to be something that is positive. And when you're faced with any information, before you give it a negative connotation, find the positivity within it first. And see it even as a challenge of something that can boost yourself to be a better person, even if there is all negative around it. Because you don't know the wisdom of challenges you don't see the result or the outcome of that until it passes. Then you will realize you've learned a lesson for something bigger to come. Thank you.
Professor Shah. Before just to translate a little bit, and I really insist, we're insisting that we translate in Kinyarwanda because we have community health workers who need to take this message back. So it's really important that we translate this in Kinyarwanda so that they have takeaway messages for them. So please bear with us as we do this, but it's very crucial for them to understand what we're talking about. Professor Shebu yari avuga ati ikintu cyangombwa ntabwo kuba umuganga, kuba umusayikatrist bitwara imyaka hafi 10. Abantu bakeneye ubufasha bwacu bari hano none, ntabwo badutegereza imyaka 10 kugira ngo umuntu ajye muri kaminuza arangize. Bavuga rero abantu mukora muri centre de santé mufasha, mukaza mu mahugurwa gutya, mugahugurwa, mushobora guhugurwa mukamenya uburyo mwakangurira abaturage uburyo birinda kugira izo ngorane zituma ubwonko bwabo burwara. So icyo kintu cya mbere yavuze. Ikindi aravuga ati ahanini gukorera hamwe, gukora n'abandi
hari ikindi yavuze cy'ingenzi cyane, kuko abaganga ari bakeya, aho twaba doctors, ni byiza ko dukora n'abaforomo n'abapsikologe bose tukabigisha, tugakorana ku buryo aho tutari bashobora kudufasha. Yavuze ko ari byiza ko dukorana, tukagira amakipe, tugakora nk'amatsinda.
Thank you very much for this very heart-touching actually approach, and also thank you very much. We have been talking about stigma about epilepsy, but there's also sometimes unfair stigma about psychiatry, and many of the people who do not realize that 90% of the human being is psych, and only 10% is chases and tires and the other hardware. The hardware is the neurology, and the software is psychiatry. And if they don't work together, the outcome is not good. And equally, it is not all health is not only doctors. Health is patient, family, community, and then it comes to medics, primary healthcare center, regional hospital, tertiary care, and then education and investigation and research and extravaganza and big ties and nice quotes. The most important message I understand here is that those are the villages and those are the grassroots must be empowered with recognition, positive support, appropriate knowledge, good training, and good life. You cannot, one person or two people, transform a country which has been traumatized by an insult which is beyond human tolerance, like Rwanda. I applaud Rwanda, I applaud people working in Rwanda, but the community here must have like continuous awareness of the importance of getting involved with psychiatric management. It does not need to be by the psychiatrists. It needs to be by the community workers, the trainers, even the community leaders. They receive training, they go back, they help people. Recognition by giving them formal training, so they will get certificates. If one gets, bachelor in community psychiatry, or even this is called for the universities to open avenues, not necessarily for medical doctors, because many medical doctors you need clinical psychologists, you need community educators. Now he is translating, which is really good, because what is the point of me speaking English and in French? And many people here, whatever English they know, they will not be able to conceive what it's what we try to communicate. So I would suggest you should build a platform, not necessarily, in complicated, but everybody has a mobile phone. If you generate just small software, basic information, post-traumatic stress syndrome, how to manage anxiety, like what we are doing for the organic diseases, which I said 10%. But imagine if you empower a mother, what to do with her ADHD child, what for a father to to do for his brother who became schizophrenic? What to do with somebody who's stressed and cannot do the examinations? What about the young bright girl who cannot go to school because she has school phobia? These things cannot be done by one person. And I don't think in my lifetime I will see where there will be enough doctors for Africa, or enough neurologists, leave alone enough psychiatrists. So I would think you should start a platform. Call it Rwanda, whatever. You have the technologies, you have clever people who can do it for you. And message to the doctors. I think in the training of all doctors in Africa, there should be a decent amount of time for training in psychiatry. Because I did neurology in the West, so it was compulsory for me to go out to psychiatry. I cannot be a neurologist if I don't understand. But is it part of curricula in our countries? It is not. So we have to push towards getting this in, not imposed, but I would think also should be in the agenda of higher education. Thank you very much.
Thank you very much, Dr. Okay. Yari aravuga ati umubiri w'umuntu ni mu mutwe. Yari aravuga ati umutwe w'umuntu ni 90% by'ibitugize. Izindi nyama indi mubiri ni 10% gusa. Ngo hakaba hari rero ni ngombwa ko abantu tumenye twita kuri iyo 90% itugize. Ikintu nyine nibyo tuvuga ni gute dukenera abakozi b'ubuzima benshi, ni gute tubageraho byihuse. Ikindi kintu yavuze ko twakoresha tekinoloji, dufite telefone, ni gute leta mwebwe muhura n'abayobozi mukaba abavugizi b'abo barwayi banyu, babyita advocacy. Urumva tukaba advocates b'abarwayi tuba dufite, tukabavugira, noneho leta igashyiramo imbaraga mu gukora iki, mu gutanga imfashanyo, mu gufasha abantu ko habaho platform. Urumva ivuga ati umwana wanjye ndabona ameze gutya, umubyeyi wanjye yagize stroke, umuturanyi wanjye yarwaye gutya, ni ubuhe bufasha namukorera, namufasha kugira ngo abashe kubaho ubuzima bumuhesheje ishema. Nibazwe tukore. Okay. So mumfashe dushimire Dr. Mukuru. Dr. Mukuru, if you have a question, please feel free to catch up with him. We're going to have a panel, and a panel that is from Partners in Health. This is what we're talking about. And Partners in Health has been, one of the major sponsors for this event, and we can't thank them enough for their support, their ongoing support in this. As you see, as you can see, and as you can hear the debate here, it's a very important topic and a very timely topic. And for me as a Rwandan, nearly 30 years, I think we should have had this, 1995 or 1994, this thing, right? But here we are. So it's a very timely conversation that we're having in Kigali. But we also have health workers from across the country who will take that message back, whatever their learnings today and over the course of the conference. They will take those messages back and then we'll reach masses that way. I'd like to invite Mr. Eric and his fellow panelists. Eric will be the moderator. I also wanted to thank Eric and the organization that he works for, Partners in Health. And I would please join me in thanking Partners in Health in being one of the major sponsors for this event. So,
Midway, we are in the afternoon already, and these discussions that we have been having here are very insightful and really very informative. And I'm really happy that this session comes after the first one you have about epilepsy, and then the one you have Dr. Arthur for this. Actually, is one of my seniors in Rwanda. I'm a medical doctor as well. My name is Eric Paganizi. I work for Partners in Rwanda. For the last 11 years, I lead clinical programs in Partners in when mental health program is under as well. So the session you're going to hear about is almost a continuation of what I've been talking about. That beyond the clinical walls, the mental health disease do not get cured into the hospital only. So as Partners in Health, we have been learning this as in a hard way. The mental health recovery does not happen in isolation. Usually it happens it doesn't only happen through medications only as well, but it has to be clinical care, psychosocial rehabilitation, family support, and community support. So that's what Dr. Arthur was saying. Our approach is really rooted into social medicine, where we look at the person, not at the disease. A holistic approach to the person. Who is the person coming to us? Where does the person coming from? What does he need? Is he really the disease from just being the disease from other conditions that are associated to that? At Partner Health, from the last 15 years, we have received almost more than 18,000 people in our mental health program, and we have tried to approach this holistically, think about the social ecosystem that the person lives in. That's why we have started programs such as problem management class at the community level, and also psychosocial rehabilitation at the community level. People come to us through different channels. Some of them come directly to the hospitals, some of them come from the communities, and you have been supporting them to get from the hospital up to the community level. That's why what you're going to hear today, what have we done, what have we learned, and actually, how is the person who lives these conditions these days? How does the person really go through these challenges, navigate the system to get back to the community and be a father, be a mother, be a sister, be a daughter. Thank you, and I'm going to invite my fellow panelists. Nagira ngo mpite mbivuga nihuse mu Kinyarwanda kugira ngo n'abandi babashe kubyumva. Partner Health Rwanda mu Rwanda abantu batuzi ku izina rya inshuti mu buzima. Niho cyane tumenyerewe. Dukorera mu bitaro bitatu, mu turere bitaro bitatu, akarere ka Kayonza mu bitaro bya Rwinkwavu, niho twatangiriye, akarere ka Kirehe mu bitaro bya Kirehe, n'akarere ka Burera mu bitaro bya Butaro. Porogaramu yacu y'ubuzima bwo mu mutwe ntabwo ari porogaramu tubona mu bitaro gusa, tuyibona no hanze y'ibitaro. Ese umurwayi batugezeho asubira gute muri community bisanzwe aho yari atuye. Tukayerekana tubivuga stigma akata abantu bahabwa bigenda gutya. Twebwe no muri PH twabifashe nk'inshingano zacu, tubona umurwayi atugezeho kwa muganga, ariko tukavuga tuti uyu murwayi namara gufata imiti hano, namara kumera neza, nasubira aho atuye biragenda bite? Ese arabaho ate? Ese arabana n'abandi gute? Ese biramufasha gute kugira ngo yongere abe umupapa, yongere abe umubyeyi, yongere abe umwana, yongere asubire ku ishuri, yongere yifashe? N'akakato abantu baha abantu bamubwira ngo afite ibibazo byo mu mutwe, bene avuga ati ntashoboye gukora, ashobora gute? Twebwe tumufasha kubinyuramo bimworoheye, kandi natwe tugafatanya na leta kugira ngo bidukundire. Muri urwo rwego njye guhamagara abantu bari bufashe mu kino kiganiro, Werasi Nsanzabaganwa, umuganga wacu ukora ku bitaro bya Rwinkwavu, adufasha kureba hari umuntu wavuze mbere yanjye yerekana igicuri, agashyiraho utuntu tw'udushushanyo dusa n'uduhagaze ukuntu. Uyu muganga mpamagaye afasha abarwayi kugira ngo tumenye koko bihagaze. Nongere mpamagare umwe mu bantu twavuye kandi n'utugikurikirana, Mwiseneza Jean Claude, ni umurwayi twafashije aturuka mu karere ka Burera, ni karibu hano. Nongere mpamagare Beata Ndagijimana, ni umukozi wa PH mu Rwanda ushinzwe porogaramu y'ubuzima bwo mu mutwe mu karere ka Burera. Nanongera mpamagare Diane, ni titulaire w'ikigo nderabuzima cya Ndongozi. Mpamagare n'umukozi wo muri RBC, Emmanuel Hakomeza, ushinzwe ubuzima bwo mu mutwe bwo mu ngimbi n'abangavu muri gace ka RBC gashinzwe ubuzima bwo mu mutwe ariko muri community no kunanusha mu basubira muri community. Murakoze cyane. So I'm going to be asking some few questions. We're going to discuss. This will be an interactive session, and I hope that at the end of the session you will be able to see how the journey of a patient, mental health patient, is in Rwanda, and how we as a country and PH are supporting the patient to go back to the community. I want to start with Werasi. You can speak in another language, I will be translating a bit. Giye kukibaza mu Kinyarwanda, wenda urasubiza mu rurimi wumva nugenda translating. When you see a patient who comes to your clinic requiring EEG, what happens? How is the patient? How do you feel? How the patient leave your office, your office with the result? How do we support that patient to get to know the diagnosis? Thank you.
Will you introduce
First, introduce yourself before. Thank you.
Thank you very much. My name is Weraris Sanzawagano. Basically, I am a mental nurse and EG technician. Me being performing EG is a way of task sharing. I'm not a neurophysiologist, but I'm able to perform EG for the last 10 years. Back into the question, as IMB works in the rural community, and as I've seen, epilepsy is among a higher number of the patients who come to us to consult in mental health clinics. So, being in the rural community, the patients also are more have burden of reduced financial means. So getting to the hospital, doctors or healthcare providers most of the time request EG to support the diagnosis. But the patient, most of the time in the past, were not able to go far in the city in Kigali to perform EG. So since we are performing EG in the little hospitals, the patients are relieved, are very happy. They say, finally, the test is done. Probably, I'm going to get treated. It's the message of relief. Even though it's not EEG who's going to treat the patient, but on one side, the patient is relieved that at least he's able to have a test that he was not able to go far perform. Thank you.
Thanks, Weraris. One of the things I want to add on before I translate to Kinyarwanda is the task shifting I've been talking about. He's not really an EEG technician, but someone who learned to perform EEG and is performing it and interpreting it properly in a rural setting, not in the city of Kigali, in a rural setting where you support the patient nearby their communities. Weraris aratubwiye ngo iwe iyo abarwayi bamugezeho akorera inkwavu ndetse akajyana burera na Kirehe kuko tutafite izo mashini za EEG zifasha kureba uko ubwonko bukora. Amurwayi amusangaho ntabwo twongera kumuhereza i Kigali ahubwo amureberaho akamuha n'igisubizo aho ngaho, bigatuma umurwayi avuga ati ngiye nsohotsemo hano ndirwa inkwavu cyangwa se ndi burera cyangwa se ndi Kirehe kandi mfite igisubizo ndizera ko ngiye kubona imiti ya nyayo ijyanye n'uburwayi mfite kuko uburwayi bwamenyekanye. Niyo mpamvu bidufasha cyane kugira ngo tumenye uko umurwayi ameze. Arakoze cyane Weraris. Jean Claude, uratangira wibwira abantu noneho unatubwira urugendo rwawe byagenze gute uburwayi bwawe.
Murakoze, nitwa Mwiseneza Jean Claude, mvuka i Burera mu murenge wa Kyeru. Ubwo nari kuva ahantu nagiye kumva numva ikintu kije nk'igicu mu mutwe, nikubita hasi nari ndi n'igare, cyakora ngira amahirwe mbona umuntu w'umukobwa anjyana ku bitaro bya Kirambo, ngezeyo bampa imiti arantegera ndagaruka ngera mu rugo. Ubwo icyo gihe mara igihe cy'umwaka nasuye kwa muganga avuga ko hari igihe abamorozi baba baranduze. Kubw'amahirwe mpura n'abajyanama bangira inama nerekera ibitaro bya Ndongozi. Ngerayo umuganga umusobanurira ukuntu nafashwe arambwira ariko nyuma gakeya nigenda nitura hasi nko mu minsi ibiri buri munsi hari n'umunsi nituraga hasi kabiri cyangwa gatatu. Noneho angira iyo nama nerekera ibitaro nsobanurira muganga uko ndwaye arambwira ati ni igicuri. Kubw'amahirwe ampa imiti nkomeza kuyirya, igihe kigeze arambwira ati jya i Butaro ku bitaro bikuru bankorera ubuvuzi ku mashini. Barambwira ati icyo urwaye ni igice tumaze kubyemezwa n'imashini. Noneho ubwo nkomeza kurya imiti ngera ku bitaro bampa randevu nkayubahiriza mbere icyo gihe kugeza na n'ubu ngubu hari n'ubuvuzi bijyanye n'ibiganiro baduhaye ubwo bazaga mu byumweru 9 bakatwereka uburyo tuganira nabo, bakatwereka n'uburenganzira twifiteho, ndetse n'igihe tugiye gusubirwa bakatubwira mu icyo kiganiro, batubwira uburyo twakwitwaramo igihe tugiye kumva tugiye gufatwa, ko tugomba kwicara ahantu tukabanza gutuza gake gake. Batubwira ko kwegera amatsinda tukaganira nayo bizadufasha. Rero icyo gihe twashinze itsinda, iryo tsinda ryari twemeza intego yo guhinga no korora. Ibyo byose tubigeraho. Nanjye ubwanje ndavuga nti nihaye intego nzageraho muri uyu mwaka. Intego niyemeje niyo kugura intama, iyo ntama ikazamfasha mu buryo bwo kuza abana banjye mbarira bakajya ku ishuri kubw'amahirwe na n'ubu. Icyo nshimira ni uko leta yadufashe kutwegereza abaganga, igihe cyose imiti tukayibonera igihe. Murakoze.
Arakoze cyane. Now, Arakoze, to summarize, his journey started when he was on the bike, then he fell down on the bike, went back home. He did not go back, think that it was serious issue, but he thought this was poisoning. Then he spent a whole year without going back to going to any clinic to see what's going on. Then at the end, he continued to have episode of fainting. Then at last he went to health post. The health post transferred him to the health center. Then the health center transferred him to Butaro Hospital, where he received an EEG examination that confirmed he had epilepsy. From that time, he started getting the right medication. Then afterward, as we are he introduced somehow the next topic I'm going to talk about. PIH supported him to integrate a self-help group so that they can start psychosocial rehabilitation. In their group, they have thought of farming as a project, and they have what they have to achieve. For himself, the aim he has is to take his children at school. Actually, he has 5 children, and also be able to buy some livestock for him to be able to sustain his life. Thank you. From that discussion that Jean-Claude gave us, we have the health facility level, but the people have to go back to the community. What happens to that level? Iyo abarwayi batugezeho bigenda gute, bava ku bitaro gute, tukagera gute muri aho batuye kugira ngo basubire mu buzima busanzwe? How does that happen?
Thank you. I'm Beata Nyandagijimana. I'm a psychologist by profession. As Dr. Eric mentioned before, we are treating the patients using pharmacotherapy or psychotherapy, and also we have patients with epilepsy. After treating our patients, most of the time our patients are doing well, but we end up finding out as we are working in the rural area that most of the patients are poor. And like the people we receive in PM Plus, which is program management approach we use as a psychotherapy approach, we find out that mostly the patient we receive, they have depression, and we find out that sometimes depression is caused by poverty. They complete 5 sessions, but after completing 5 sessions, you find out that the cause is not really tackled, because they go back to the poverty, which means the relapse may come. The same way also with patients with epilepsy, they may be taking medication, but sometimes they end up stopping taking medication because of lack of food. So that's where we have to think about, when they go back to the community, how can they continue living? Even their family have to live. That's where we're providing like a social support, like food package, but this is something which can help them like 1 week or 2 weeks, while the family have to continue living. That's where comes a psychotherapy approach, where this is a non-structured curriculum which has 9 sessions. where we put the patient in a group of 15. We teach them different sessions, like as you mentioned about gender-based violence, because some of our patients are facing violence in the community and they don't know their rights. We teach them how to set their personal goal, because before they achieve the goal, they should set the goal before. We teach them how, we strengthen their capacity to set their personal goal. If, as he mentioned, like they are doing farming, others are doing agriculture, others are doing tailoring. So the goal is set based on patient interests and also capacity or ability, because they are not all at the same level of improvement. That's why we should look on patient capacity or ability or functioning, so they can choose what they are interested in doing based on their capacity. We also teach them about relapse prevention, because sometimes our patients, you find out that sometimes they don't know the signs and symptoms, but through those models, we teach them how to recognize their signs so that they can immediately go to the hospital before the illness attack them. We also teach them on getting along with other people, like communication skills in their business. Because when they start the business, for example, like tailoring, they should know how to communicate to people in order to attract the clients. So all those skills are being taught. So he's among the patients who completed those sessions. And we also assessed the improvement or the outcome of the session using a tool called the WHODAS, that's World Health Organization Disability Schedule, which mostly is looking about the disability due to mental illness. We also use another tool called the RAS, which is Recovery Assessment Scale, which mostly focus on the recovery. So actually, we assess them before they start the intervention. We also assess them during the intervention and at the end also of the intervention. So those we started with, the score showed that they are really improving, which means the intervention is being scaled up to other health centers where patients are being helped in the community. And what I can also add on that is that it's not PIH, which is already delivering the intervention. We work with the health center. We have psychologists and psychiatric nurse or social worker who are delivering the intervention, which means even non-specialized people, they can support the mental health patient. Thank you.
Thank you, Beata. Magambo make Beata atuganirije ku buryo abarwayi bava kwa muganga bakagera aho batuye bagakomeza gufashwa bijyanye n'abantu bose ari abavuzi bo kwa muganga, abaganga bo bari bakora kwa muganga, ndetse n'abo basanze muri community. Abarwayi bakajya mu matsinda y'abantu 15 bagakora bakiga inshuro 9 ibyo bigisha, bakanabafasha kwishyira muri ayo matsinda, bakishyiraho intego zabo z'ibyo bazageraho bitewe n'uko bahagaze n'uko babonaho icyo babasha kugeraho. Hakaga intego y'itsinda aho intego z'umuntu ku giti cye bitewe n'icyo ashobora kuzageraho, kuko abantu bafite uburwayi butandukanye. Ikindi kiriho muri ayo matsinda bafashanya kwigiranaho uburyo babasha guhangana n'indwara barwaye, kandi bakaniga uburyo babasha kumenya niba bagiye kongera gusubira mu burwayi bukabije bakajya kwa muganga hakiri kare. Nuko ayo matsinda bahora babareba uko bahagaze, ndetse bakanamenya niba umuntu yabashije kugera ku nakwita ku gukira. Muri ibyo, all of this is done at the community level, but the patients are at the facility level. In Rwanda, the facility are run by healthcare professionals, but we are trying to have a model that integrates both the health facilities and the community. That's why today we have one lead of our health center, Diane, who leads one of the health centers that will start this program. Diane, umuyobozi w'ikigo nderabuzima, ubundi tuzi ko abayobozi b'ibigo nderabuzima bari kwita cyane ku bijyanye n'ubuvuzi.
ese mwebwe ku kigo nderabuzima cya Ndongozi kugenza gute kugira ngo mubashe guhuza ibyo kuvura cyane cyane abantu bafite urwego mu mutwe ndetse mubashe no kubakurikirana aho batuye mubashe no kubafasha n'abantu bakorera kwa muganga wenda batangira bibwira abantu bari hano.
Murakoze cyane. Amazina nitwa Iradukunda Diane, ndi umuyobozi w'ikigo nderabuzima cya Ndongozi ni muri Burera Amajyaruguru y'u Rwanda mu bitaro bya Butaro. Murakoze ku kibazo cyiza mubajije. Nibyo koko abayobozi b'ibigo nderabuzima tugira inshingano nyinshi, ariko duhereye aho twatangiye kugeza uyu munsi ku biganiro byose byagiye bitambuka, ubuzima bw'umuntu ntabwo bushingiye ku buzima bwo mu mutwe. Rero iyo tuvuze umuntu ufite ikibazo wenda cyo mu mutwe, wa muntu ari muri community. Muri community nta handi dutuye, hari abaturanyi, hari abanyamuryango bacu, hari abayobozi b'inzego z'ibanze, hari n'abajyanama b'ubuzima. Rero uwo muntu iyo agize ikibazo, izo nzego uko zikurikirana navuga ko zifite uruhare rukomeye cyane ndetse tunashimira mu gufasha uwo muntu. Ni ukuvuga n'ibyo koko ubuvuzi navuga butangirira hahandi kuri community, kuko niba bamubonye baramufasha bakamuzana ku kigo nderabuzima. Rero iyo bamuzanye twebwe tumufasha mu buryo butandukanye bitewe n'ikibazo umuntu afite. Dufite ubuvuzi navuga buri mu byiciro bitatu. Hari ubuvuzi bushingiye ku biganiro, hari ubuvuzi bushingiye ku miti, ariko hari n'ubuvuzi bwo gusubiza umuntu wagize ikibazo cyo mu mutwe mu buzima busanzwe. Ubwo buvuzi rero butangwa n'abantu ku byiciro bitandukanye. Hari abaganga cyangwa se aba professional nurses baba bahari ku kigo nderabuzima, baba bari aba professionals mu bintu bijyanye n'indwara zo mu mutwe, ariko tuba dufite noneho n'umunasi twagize amahirwe PH iraza itanga formation. Abantu nyine ku buzima bwo mu mutwe twese turabukangukira, umuntu wese yasanga ku kigo nderabuzima umurwayi cyangwa se uwo mukiriya uje tugana arafashwa. Mu by'ukuri rero kubihuza n'inshingano zacu za buri munsi ntabwo ari ibintu navuga bikomeye. Icya mbere ni ukubiha agaciro, tukumva ko ni ibintu byacu, tukumva ko ni ubuzima bwacu bwa buri munsi, kandi tukirinda ko wa muntu yagira ikibazo cyo guhabwa akato. Akato ka mbere umuntu yakagira ari twebwe tubiteye. Rero niba umuntu habayeho ibiganiro muri community irigishwa ko ubuzima bwo mu mutwe ni ubuzima nk'ubundi, nk'uko umuntu yarwara mu nda, nk'uko umuntu yarwara urundi rugingo, ariko noneho ku mutwe ho bikaza byihariye. Ari niyo mpamvu dukeneye ko community ibimenya cyane kurushaho. Rero ntabwo dutanga wenda ubwo bufasha ku rwego navuga rw'ikigo nderabuzima gusa, oya, no muri community turamanuka tugatanga ibiganiro, abantu bagasobanukirwa ubuzima bwo mu mutwe, bagasobanukirwa umuntu wagize ikibazo kijyanye n'ihungabana cyangwa se n'urwego mu mutwe afashwa gute by'ibanze, bigenda gute. Urumva ko duhera hasi, duhera kuri community, bijya kutugeraho twebwe ubona abantu navuga bari muri modo. Ibi ntabwo byahozeho mbere ya 2012 decentralisation y'ubuzima bwo mu mutwe itarabaho. Ntabwo ari uko byagendaga. Umuntu yagira ikibazo cy'urwego mu mutwe nyine abantu bose bakitaza bakamukwena, kubona nyine aratererana. Uyu munsi navuga ko iwacu Burera atari ko bimeze, cyane cyane wenda muri zone y'ikigo nderabuzima cya Ndongozi, kuko twebwe by'umwihariko twahawe amahirwe y'uko ukuntu bavuze dutanga ubuvuzi bwa social rehabilitation, gusubiza wa muntu noneho mu buzima busanzwe byahereye iwacu. Turi abanyamahirwe cyane, byahereye iwacu, turanabikunda. Umutangabuhamya wabyo bitangira nanjye naribazaga ese bizagenda gute ibi bintu, noneho PH bagiye kurema ikidashoboka. Nanjye ntabwo numvaga ko bishoboka, ariko mu by'ukuri byarashobotse ndazishobokera cyane, aho abantu bose twari dufite bitabiriye bya biganiro bose 100% byabagiriye umumaro kandi barakize. Icyo navuga ni uko ari intego bihaye bazirimo neza, kandi ubona ko